Hello everyone, my name is Ifeoma Ogbalu. I am a DMP student at the Maryville University and I'm here to give a presentation on my scholarly project titled Improving Depression Screening by Using the Patient Health Questionnaire 2 and 9 in the Primary Care Clinic. These are my committee members. The chairperson is Dr. Rita Wunderlich. The second committee person is Izinwaya Zokari. What is depression? Depression is one of the common mental health disorders in the United States and a major contributor to worldwide disability. Depression accounts for about $30 to $50 billion annual losses in productivity and direct medical costs. But there is a good news. Depression can be accurately diagnosed in a primary care setting. And it can also be diagnosed at an early stage in such setting, which is likely to improve the patient's outcome. But there is a twist. Although depression can be detected in the primary care setting, it is undetected about half the time it is present. And this low recognition amounts to about 36.4%. Depression screenings, when implemented properly in the system, helps to assure accurate diagnosis of depression and also helps to effectively treat and appropriately refer or follow up a person who has depression. The utilization of Patient Health Questionnaire 2 and 9 depression screening tools have been identified by the Agency for Healthcare Research and Quality as literature's best screening practice tools. And what is depression? These are the signs and symptoms of depression: persistent feeling of sadness, low interest in activities which one usually enjoyed before, trouble sleeping or sometimes oversleeping, a loss of appetite or eating more, fatigue or decreased energy, difficulty thinking clearly or quickly, being irritable, angry. In elderly people, sometimes the depression comes up as somatic symptoms, such as physical aches and pains. And also another symptom that could be seen with depression is recurrent thoughts of death or suicide. The significance of this study is to three aspects that I have identified. One, to the advanced practice nurses, it would equip advanced practice nurses with knowledge on how to use depression screening tools such as the PHQ-2 and 9 to facilitate the early detection of depression and also to ensure referrals are made to the psychiatric providers as the case may be. Also, the significance of this study could help healthcare by reducing the medical costs and mortality rate caused by depression. The third aspect where this project could be useful is in quality and safety to help the delivery of practice excellence depression care and awareness by creating organizational policies that reflect respect, equity, and values of patients with mental illness. The purpose and aim of this project is to determine if an educational intervention reviewing the Patient Health Questionnaire 2 and 9 will improve post and compared to the pre-intervention compliance of the following. 1. Completion of the PHQ-9 if the PHQ-2 is a score of 3 or greater. Then the second one is if a mental health referral was initiated if the screening was indicative for depression. So the overall aim of this project is to promote the adherence use of the PHQ-2 screening tool in primary care setting and thereby facilitate the diagnosis of depression. My pico question was, in primary care adult patients, does the consistent use of the PHQ-2 and 9 screening tools effectively detect depression and facilitate the timely initiation of referrals when depression is indicated compared to the use of no screening tools? For the literature search, it was conducted using the following quality search engines. I used the Academic Search Complete Database and the Cumulative Index to Nursing and Allied Health Literature, that's the CINAL. And my search terms were the PHQ and evaluation for referral or assessment or evaluation, and primary care. Specific Bolivian phrases were used, like the PHQ-9 and screening tools and evaluation for referral. A total of 20 articles were applicable for use in this project after reviewing and refinements. Articles were retrieved and obtained from the peer-reviewed journals published between 2013 and 2020. 4 terms were derived after reviewing the 20 articles. The first term was primary care setting, and it was found out that depression can accurately be diagnosed in the primary care setting. The second term was screening instruments. There were various screening instruments that were identified, but the PHQ-2 and 9 were mostly the commonly used ones in the primary care setting. The third theme was time efficient and cost effectiveness and language. The PHQ-2 and 9 were cost effective questionnaires. They were used in many academic and medical centers due to their brevity. They were really short to complete. Then the fourth theme that I derived from the integrative review of literature was that the reliability and validity of the PHQ-2 and 9, it had good internal consistency. So I was able to evaluate the strengths of this evidence. I found out that those 20 articles that I used to support this scholarly project were randomized and non-randomized studies, case control studies, descriptive studies. The strengths of their references were between 1 to 7, and evaluation of the evidences shows that more quality studies are needed. So the theoretical framework for this project was the PENDA's health promotion model. It just shows that before a change is done, the person has to perceive the benefits. So this changes on the aspect of the healthcare workers. For them to be able to implement the screening tools, they have to perceive the benefits of their actions. They also have to perceive the barriers to their actions, and also evaluate how effective are they at using those screening tools, and also assess their interpersonal influences. What is influencing them? What is motivating them? What is hindering them from applying those screening tools when they are trying to assess the patient? Then when all these are done, they could effectively commit to a plan of action on how to improve and how to then promote healthy behaviors. That's how to promote health for their patients, the patients they are seeing. So the measurable objectives for this scholarly project was to get a letter of approval from the primary care clinic where the project will be conducted, as to show as evidence that they have given the permission to release the adult patient's electronic medical records. Then 2, to obtain the IRB from Maryville University. Then 3 was to provide an educational intervention that will be reviewing the PHQ-2 and PHQ-9 screening tools from February 1st, 2021 through to February 15, 2021. So after the reviewing of this educational intervention, collection of the pre-intervention data will be from the time frame of December 1st, 2020 to January 31st, 2021, and the post-intervention data will be collected after the conduction of the educational review, which is from February 16 to April 30th, 2021. Then after the collection of this data, statistical analysis will be conducted. Then afterwards, we'll then establish plans to disseminate the findings. So this scholarly project is a quantitative explorative design through retrospective chart reviews. Entailed the extraction of 154 electronic medical records. So the inclusion criteria for this project was that all patients were adult patients. They were 18 years and older, and they were seen at the clinic between the pre-intervention time frame and the post-intervention time frames written here on the slides. Exclusion criteria were that the patients who were less than 18 years of age were not included, and patients Yeah, patients who were less than 18 years were not included, and patients who were not seen within the pre-intervention time frame and the post-intervention time frame were not also included, among other criteria. So the setting where this project was conducted was at a primary care clinic located in the southwest region of the United States. There was no donation for this project to be undertaken. Consultations were made between this researcher and the staff at the clinic, which entailed a doctor and 2 nurse practitioners and some RN, about 3 RNs. And also collaborations were done between this researcher's chairperson and the committee member. So the intervention was just to go over to re-educate, because the clinic also uses the PHQ-2 and PHQ-9 screening tools. But the idea of the intervention was to go ahead and re-educate the staff members about these tools and how to interpret the scores and what interventions to do when they obtain the scores of the PHQ-2 and the PHQ-9 screenings. Also, the intervention was also, the education given was also to promote the compliance of the evidence-based practice guidelines related to the use of the PHQ-2 and PHQ-9 screening tools in primary care settings. And also to facilitate the diagnosis of major depression in the patients that they treat. So the data collection tools used for this project was the PHQ-2 and 9 screening tools, and it entailed the scores like 5, 10, 15, 20 respectively were cutoff points for mild, moderately severe, and severe depression, and scores that were above 15 were necessary for referrals. Another data collection tools that was used was the data collection sheet. This is just a Microsoft Excel spreadsheet where the PHQ-2 and 9 screening tools were translated from numeric values, which they were, to some ordinal points base. That's like if the PHQ-2 score was administered, it would be a 1. But if it was not completed by the provider, it would be a 2. And if the PHQ screening tool was the PHQ-9 screening tool, if it was administered, it would be a 1. And if it was not, it would be a 2. And if it was not applicable, it would be a 3. So these were the scales I used to input my data in the data collection sheet. So the procedure for this project was that after the IRB approval was obtained from the Maryville University, data collection began. April 30th, a written list of these patients that were staying at the clinic was collected from the clinic's manager, and the second step was re-educating everyone, the staff members at the hospital, at the clinic. Education began on February 1st through to February 15th of 2021. Each EMR that was provided on the list was reviewed to see for inclusion criteria if it was met. Then the first stage was the EMR used in the project was given numerical numbers on the data sheet. The minimum necessary data was collected for this project, and no patient identifier was included. The data collection process stopped when the researcher reviewed the anticipated number of EMRs for this project. Then once the data collection stopped, the written list retrieved from the clinic's manager was returned and destroyed. The temporary password that was given to this researcher was deactivated. So once the data were achieved using the SPSS, I was able to do the Z test. So the Z test for the difference of 2 proportion was used to analyze the outcome for this research, and this was the outcome, which would later explain in the data analysis part. So this was summative data analysis, and the results showed that there was increased screening using the PHQ-9 tool and increased referral cases after the re-education was given. We could see that from this data, this was a pre-re-education intervention. This was the number of patients that were seen, at the clinic, and number of patients that were given the PHQ-9 versus the number of patients that were on screen. So this was the number of patients that were given the scale here would help. The blue was the screen, and the yellow were the number of patients that were on screen using the PHQ-9. And these are the numbers of patients that were referred, that is prior to the re-education intervention. And post-intervention, the number of screened people, this is the number of screened people, and this is the number of people who were unscreened. And these are the number of people that were referred after the re-education intervention. So discussions of the finding. After using the z-test for the difference of two proportion, we were able to calculate a p-value of 0.0203, which is less than the significance value of 0.05. And this shows that there is sufficient information to suggest that there is an increase in ratio of pre to post education intervention population. So the number of patients that were screened after the re-education intervention increased from 21, which was the pre, to 33, which is the post. And the number of patients that were referred post re-education increased from 9, which was the pre, that was the number of patients that were referred before the education intervention was done, to 20, which is the number that was gotten post intervention. So the calculation using the z-test for the difference of two proportion, we're able to find out the confidence interval for this data analysis was at the lower limit of 0.0125 and the upper limit of 0.4171, which suggests that there was a change in between those population. And also the result also showed that the delivery of this re-education intervention suggests that there was marked improvements in the skills and self-efficiency of the healthcare workers using the PHQ-9 and 2 tools. So consequences of this study and unintended consequences were: this project has promoted the consistent use of the PHQ-2 and PHQ-9 depression screening tools, thereby facilitating referrals for positive screening, which led to early diagnosis of major depression and treatment initiation. Also, one of the unintended consequences of this project was the uncontrollable nature of the COVID-19 pandemic. Because of it reduced the number of patients that were visiting the primary care clinic, and subsequently reduced the number of adult patients' records that were extracted from the electronic medical records for this project. So hence, a total of 81 patients' EMRs were extracted for this project. Limitations of this study included the reduced number, like earlier said, the reduced number of patients that visited the clinic due to the pandemic. Findings of this project can only be generalized to this primary care clinics population, but cannot be generalized to other primary care clinics. However, information bias was prevented by this researcher by utilizing the standard evidence-based practice guidelines of the PHQ-9 depression screening questionnaire. Also, observer bias was averted by retraining the clinicians on how to utilize the PHQ-9 screening tools. Implication of practice and future research. So this research hopes to, positively influence social change by reducing the incidence of undiagnosed and untreated depression among patients who are seen by providers at the primary care clinic and the healthcare centers too. Reduction, it also helps to reduce financial burdens to economy, because remember earlier said that depression costs about $30 to $50 billion to the economy. So the implication for this research, if depression is able to be caught on early and referrals are made, treatments are followed, it would reduce the financial burden of the economy. Also, it would also help improve clinicians' knowledge and enhance their confidence level to diagnose depression. Implication for healthcare policy. This research seeks to, equip advanced practice nurse practitioners to lead and participate in designing systems of care and policies that promote appropriate depression care awareness to reflect respect, equity, and value for the patients with mental health illness. Implication for quality and safety. This project would enhance depression screening literacy, and it will also empower clinicians to screen for depression at all healthcare settings. It will also contribute to the delivery of practice excellence and quality patient outcome and satisfaction. So recommendation and conclusion for this project. My conclusion is that this project shows that the PHQ-9 re-education of healthcare practitioners evidently helps remind and motivate the frequent use of the screening tool to detect depression in the primary care setting. This project also shows that the PHQ-9 re-education that was given also prompts the users on what to do next when each of the scores are gotten. When it's a 5, what do you do? When it's a 10, what do you do? When the PHQ score is a 10, what do you do? When it's a 15, what do you do? So this re-education program would help prompt the healthcare providers on what to do next when they get each PHQ scores. And although the finding of this study favored a positive change, further studies should be implemented over a longer period without the limitation experienced during this study to verify the replicable findings of this study in a different or in a similar setting. And the following are my references. Thank you.